guys, I'm going to do my case study on pancreatic cancer. So just starting with the anatomy here. The pancreas is considered a glandular organ and it's approximately 6 to 10 inches in length. It's considered a retroperitoneal and there are multiple organs surrounding it. So if you kind of look at the picture, there's both kidneys right by it, the duodenum, the spleen, the gallbladder, stomach, and then lots of vessels and ducts through this area. So the pancreas consists of three main parts. There's the head, which is located where the stomach and the duodenum meet, the body, which is the central portion, and then the tail, which is the thinner portion that extends towards the spleen. So the pancreas has two main functions. Those are endocrine and exocrine. Exocrine function helps produce enzymes that create pancreatic juices and bile, which will get released into the duodenum and aid in digestion. Endocrine will use islet cells that help create and release hormones into the bloodstream. And the two main hormones that are created are insulin and glucagon. Insulin helps lower blood sugar, whereas glucagon helps raise blood sugar. Epidemiology. So pancreatic cancer accounts for approximately 2% of all cancers. The highest incidence of pancreatic cancer is in more developed countries. It's the fourth leading cause of cancer deaths in the U.S. and considered one of the most lethal. It's slightly more common in males. The median age is between 50 and 80, but your risk of pancreatic cancer does increase with age, and it is 25% higher in African Americans versus Caucasians. The histology and pathology. So the histology will be broken up into those two categories I mentioned earlier, the endocrine and the exocrine. So the exocrine tumors are the most common. The most common type of histology is the pancreatic ductal adenocarcinoma, or PDAC. Then the second most common will be the mucinous tumors, and then following behind will just be giant cell carcinoma, papillary cystic carcinoma. And for endocrine, these account for less than 5% of all pancreatic tumors, and these are going to be called pancreatic neuroendocrine tumors, or PNET tumors. And these can be either benign or malignant, and they tend to grow slower and are less aggressive than the exocrine tumors. And these tumors will kind of mess with the hormone levels and increase the production of them. So as for the pathology, the pancreatic ductal adenocarcinoma will originate in the epithelial cells that are lining the pancreatic duct. The mucinous tumors will arise from the pancreatic ductal epithelium, and the pancreatic neuroendocrine tumors, or the PNET tumors, will originate from those islet cells that are helping produce those hormones. So as for the spread, it will start with local invasion, just some of those surrounding organs that I mentioned earlier. So the bile duct system, the duodenum, the stomach, or the spleen. Then from there, we'll go to the lymphatic system. The lymphatic chains that are right around that area are the peripancreatic, the hepatic, and the para-aortic. And it is really common to have lymph node involvement at the time of diagnosis. And from there, we'll go to distant metastasis, which is liver, lung, or any other distant organ that's located within the abdomen. Approximately 50% of all patients will have distant metastasis at their diagnosis. So just some risk factors here. Smoking is probably the biggest risk. It will increase your chances by about 2 to 3 times. Then it just kind of comes down to age, diet, obesity. Family history comes into play a little bit. If you have hereditary pancreatitis or history of breast cancer, ovarian cancer, melanoma, Leigh-Fermani syndrome, all that can kind of come into play. Chronic pancreatitis, hepatitis B, or if you have cirrhosis. So this is my patient. My patient was a 55-year-old Caucasian male. He was a non-smoker. He was divorced. He had 2 adult-age sons. He unfortunately had no reliable caretaker, and prior to his diagnosis, he would work 12-hour shifts at a production plant and a machinery plant. So this is his diagnosis. He presented with unexplained weight loss, about actually 60 pounds of unexplained weight loss, beginning in September of 2017. So he had a CT abdomen pelvis, which showed a mass in his pancreatic head. Then he had an endoscopic ultrasound with a fine needle aspiration, which actually was kind of just a scope that kind of looked at all his organs down there, and it also was considered part of like his biopsy. Then he also had a ERCP with a metal stent placement. All these tests combined confirmed a mass that was 4.2 by 2.7 in the head of his pancreas, and there was a little bit of spread to his duodenum. He was diagnosed with stage 2 pancreatic carcinoma, and it was considered borderline resectable. So he was put on Follifornux, and he went through a whole chemo regimen of that. And then he had what's called like a restaging CT, and unfortunately that restaging CT showed a mass on the left upper lobe of his lung, and then it showed an increase of the tumor size that was in the head of his pancreas. So after that, his doctors decided to do radiation therapy with concurrent a different regimen of chemotherapy, the 5-FU, and they were hoping to possibly do surgery after his treatment. So staging and grading. So staging is the spread, and it really depends on the resectability for pancreatic cancer. So they kind of just label it as like resectable, borderline resectable, or unresectable, and then they also use that with the TNM system. As for grading, just looking at cell differentiation, it goes 1 to 3, but grading also kind of depends on the extent of resection of the tumor. So R0 being the tumor has been completely removed, and then R1 being that the visible tumor has been removed, but there's probably still traces of cancer in the area, and then R2 is just that they did the surgery and they couldn't remove all of it, so there's definitely still some visible cancer behind. Okay, so for treatment, the treatment of choice is surgery or radiation therapy. They have just like a very similar outcome, so there's no preference of choice, kind of just depends. So surgery, the biggest surgery is the Whipple's procedure, which is used for tumors that are localized in the head of the pancreas. It's a very high risk procedure. It's the removal of the head of the pancreas, the duodenum, the gastric antrum, bile duct, and the gallbladder. So it entails a lot there. Tumors that are located in the tail will kind of remove the tail of the pancreas, and then also a lot of times they'll remove the spleen as well. So if radiation therapy is used, there's lots of different methods that you can use. You can use 3D conformal technique, you can use IMRT, you can use SBRT, VMAT, IORT, you can do interstitial brachytherapy. So if interstitial brachytherapy is used, the source would be iodine 125, but that's pretty rare nowadays. And then if IORT is used, it would typically be like a single fraction of 10 to 20 gray electrons. And this procedure is just beneficial because it helps shield the surrounding organs. So chemotherapy is typically used in combination with each other. So kind of just laid it out. So my patient had the Follifornux. So that is a combination of a bunch of different chemotherapies. So a lot of times they will do that Follifornux combined with a different therapy, such as the 5-FU. And then sometimes they can do targeted therapy, which tries to target specific genes or proteins that are contributing to the cancer growth and try to stop them. And the treatment of pancreatic cancer, since it is often found at a later stage, is just managing the side effects. So a lot of times they're just doing pain management or managing like if they're having diabetic symptoms or just like relieving any blockages from the ducts or anything like that they're having. So this is his prescription, and his treatment plan is beam orientation. So his treatment goal was definitive. He was having a 6 MV VMAP photon treatment, 28 fractions, 180 centigrade per fraction at 5,040 centigrade total. And he had 2 treatment fields. His first field was just clockwise at 211 MU with his SSD at 83.82, 93 centigrade per treatment. And his second field was counterclockwise at 180 MU, 83.96 SSD, 88.5 centigrade per treatment. And as I said earlier, the goal of all this radiation treatment with his concurrent chemo was to shrink the tumor enough to make him a better surgical candidate. So just kind of recapping, so he had a borderline resectable disease. He was started on that follow-up Fornex, and at this time, while he was having his EVRT, he was having concurrent 5-FU chemotherapy. And he is currently on tons of pain medications because he's in a lot of pain. This is his treatment setup. So he was just supine. He had a wingboard headrest B and a wedge under his knees. And then these are his port films, his isodose curves. And this is his DVH. As I said earlier, the pancreas is just located by a lot of organs, so he had a lot of OAR. One of the biggest ones being his aorta, which was receiving about 1,069 centigrade. Both of his kidneys were receiving about 930 centigrade. His bowel was receiving 424 centigrade. Spinal cord, 286 centigrade. His duodenum, 1,506 centigrade. His esophagus, 104 centigrade. His gallbladder, 2,117 centigrade. His stomach, 792 centigrade. His spleen, 574 centigrade. His heart was receiving 26 centigrade, and his lungs were receiving 31 centigrade. So just a lot of organs at risk in this treatment. So, as for his side effects, just the common side effects that people could experience when receiving like pancreatic radiation therapy is nausea, vomiting, fatigue, diarrhea, and weight loss. They can have like skin reactions or erythema, but it's pretty uncommon. So as for his treatment visit, all of his visits he was having abdominal pain that he rated between a 7 and an 8. But that was present before his treatments began. His Karnofsky score was an 80, which is actually pretty good for considering how much pain he was in. He had normal activity with effort, and he had some signs of the disease, but it didn't quite affect like his typical daily activities. All his vital signs were normal, and he had no acute radiation side effects, and all his pain was being managed by various doses of oxycodone. As for his prognosis, pancreatic cancer has a high mortality rate with a very, very poor prognosis. It's very dependent on the resectability of the tumor and the stage it was diagnosed at. Pancreatic cancer is just like extremely difficult to diagnose. There's really no specific screening tests or anything that you can do, and the symptoms of pancreatic cancer can often be mistaken for other medical conditions, so that can also come into play when it comes to an earlier diagnosis. And just due to all that combined together, all this, it's often just diagnosed at a later stage. So as for the 5-year survival rate, in general, the 5-year survival rate is 9%. The early stage, if it's found just with that local just right in that localized in that one area, it's about 34%. If it's just locally spread, 12%, and if it has distant metastasis, it's about 3% for those 5-year survival rates. And my references.